This lecture series is named after our beloved leader and founder of Home on the Hill, Bob Veltheer. And I truly believe that every time we have one of these lectures and everybody comes together, that we keep his memory alive that way. And he actually lives with us all in spirit as we have this lecture series that is very special and is named after him. So it truly is an honor for me to be here and be able to introduce that. It now gives me great pleasure to introduce Marvin Ross. Marvin Ross will be introducing our key speaker for tonight, Dr. Nick Cates. Marvin is a Dundas, Ontario writer, a Huffington Post blogger, and a celebrated publisher with a particular interest in mental health issues. Marvin has been described as one of the leading Canadian advocates for individuals with serious psychiatric disorders.
I'll cut this down a bit because I want to give Dr. Cates sufficient time, but since 1997, he has been the co-chair of the Canadian Psychiatric Association College of Family Practice Collaborative Working Group on shared mental health care in Canada, a neighbor of mine, actually. And I want to read you something that he wrote in 2006. Our vision for mental health care in Canada is to be integrated in a public health system with health care providers from a variety of backgrounds, working in partnership with consumers and their families, communities, and each other to enable consumers to access prevention, health promotion, treatment intervention, and rehabilitation services from the most appropriate provider when they need it in a location that is accessible and with the fewest obstacles. I was also going to talk about the Hamilton Family Health Team, which is the largest in Ontario and which Dr. Cates is affiliated with. But I think he is going to talk about that, and all I can say is, as a resident of Hamilton, I'm a member of that family health team, and we actually find it absolutely excellent and quite a model for how healthcare should be provided in Ontario. So, Dr. Cates, I'll turn it over to you.
What I want to do, I'm going to try and pull together 2 or 3 different things into kind of one presentation. I want to focus primarily on personal and family-centered care and how the title, which actually came from Kathy, but really having an authentic family voice in the healthcare system, some ways in which it can be achieved, and want to look also at the model that Marvin referred to, which is what happens when mental health services are integrated in primary care, and how can that build on some of the points, hopefully, that I'll have raised in the first part of the talk, to look at how not only care can be enhanced, but families and people with lived experience dealing with mental health issues can receive much, find a place where they're valued and their voices are heard. So what I'd like to do in terms of the outline, just talk a little bit about what is personal and family-centered care, how can we do better, ways of involving individuals and families in their own care, and then talk about a little bit about collaboration between mental health and primary care and how that can improve the user's experience of care. And I apologize in advance. I'm going to go backwards and forwards with my terminology. Sometimes talking about people, individuals, users, people with lived experience. But, I think you know who I'll be talking about in each of those situations. And I'm going to use as my point of inspiration Winnie the Pooh. Here's Edward Bear coming downstairs now, bump, bump, bump on the back of his head behind Christopher Robin. It is, as far as he knows, the only way of coming downstairs. But sometimes he feels there really is another way. If only he could stop bumping for a moment and think of it. And I think that's where we are with the healthcare system. We know we're underperforming in so many ways. We know we're a long way away from a true person and family-centered system. And I believe that all the pieces are there. We know what to do. But how can we sort of stop bumping, stop doing what we've always done, do things differently to get different outcomes? This was a study in the States. It was really a landmark study because it introduced the quality improvement model, and I'm going to refer to that in a couple of ways during the talk. But they said between the healthcare we have and the healthcare we could, and I've added should have, lies not a gap but a chasm. These quality problems occur typically not because of failure of goodwill, not because it's not because we don't want to do better, it's not because we don't know how to do better, it's not because we don't have enough resources, but it's fundamental shortcomings in the way our systems of care are organized. And we've got caught up in practices and ways of doing things that we can't get out of that prevent us getting different outcomes. When I talk about quality improvement, and this is the only slide where I'm really going to talk about it, but this is sort of my frame of reference for looking at a healthcare system. We talk a lot about what is a high quality system. This is just one attempt to define it. So when we talk about improving quality, I think we're looking at a system that is above all safe and effective. It does what we know works, and what we do does work, and we do as little harm as we possibly can along the way. It's care that is timely, and it's consumer and family centered, and it's care that's equitable. And I think in my time in healthcare, I've come to believe that equity is the most important of all of these quality domains. If we don't have equity in access to treatments and in outcomes, then we're always going to be falling short. It's efficient, it's integrated, and it's focused on populations as well as individuals. So we're thinking about who we don't see and how they're doing, as well as the people we do see. And I'll say a little bit about a couple of those as we go along. So firstly, what is person and family-centered care? Let me use as a starting point a short video. And this is someone called Don Berwick. Don Berwick is, if you like, the father of the quality improvement movement in the States. And this, I think, highlights some of the ways in which we're falling short at the moment. So let me,
I fear to be a patient. Partly that fear comes from what I know about technical hazards and the lack of reliability in care.
Sorry, just pause it for a moment. This is not specific to mental health. What he's talking about is just his experience as a patient in the healthcare system. But I think he's going to touch on so many themes that not only, I think you'll be able to connect with because of your experience, but I'm going to use as a kind of point of departure for this evening.
Today I have bone-on-bone pain and osteoarthritis in my right knee. I can no longer jog, which was my passion, or even run 4 steps because I had an unnecessary and now fully discredited knee operation as a medical student, an operation that had never been subjected to proper evaluation for a condition that had never been subjected to a hands-off arm of a clinical trial. My best friend had a severe post-operative complication from a drug dosing error at transition. It almost killed him. My research on errors in care showed these errors to be terrifyingly the norm. But the honest truth for me is that the errors and unreliability of healthcare are not the main reason that I fear that inevitable day on which I will become a patient. For in fighting those enemies, errors and unreliability, I am aligned with the good hearts and the fine skills of my technical caregivers. I can use my own wit to stand guard against them. What chills my bones is indignity. It is the loss of influence on what happens to me It is the image of myself in a hospital gown, homogenized, anonymous, powerless, no longer myself. It is the sound of a young nurse calling me Donald, which is a name I never use. It's Don. Or for her, maybe it's Dr. Berwick. It is the voice of the doctor saying, "We think," instead of "I think," and thereby placing that small verbal wedge, the pronoun we, between himself as a person and myself as a person. It is the clerk who tells my wife or my son to leave my room, or me to leave their room, without asking if we want to be apart. A close friend called a clinic for her mammogram report, and she was told, "You have to come here. We don't give that information out on the phone." She said, "It's okay, you can tell me on the phone." And they said, "No, we can't do that." Of course they can do that. They choose not to do that. And their choice trumps her choice, period. That's what scares me. It scares me to be made helpless before my time, to be made ignorant when I want to know, to be made to sit when I wish to stand, or to be alone when I need to hold my wife's hand, or to eat what I do not wish to eat, or to be named what I do not wish to be named, or to be told when I wish to be asked, or to be awoken when I wish to sleep. You can call it patient-centeredness if you choose, but I suggest to you this is the core. It is that property of care that welcomes me to assert my humanity and my individuality and my uniqueness. And if we be healers, then I suggest to you that that is not a route to the point. It is the point.
So, I mean, I've seen that countless times. I find it moving every time I see it, because what he's talking about is exactly what we're aiming towards, you know, the humanity of medicine and one person connecting with another person, and all the obstacles and barriers that we erect, we as healthcare professionals, that make that so much less likely to happen. So, I mean, that really is a big part of what I want to focus on today, how we can get towards something that is different from the situation that he's describing. And the other thing I think that strikes me is that so many of the things that he's talking about are little things. They're not big things. These aren't major transformations. They're just asking before you tell. They're just treating someone the same way as you would want to be treated if you were in that situation. So when I use the phrase, talking about compassionate, and I think each of these words are important, compassionate, respectful, culturally sensitive care that is responsive to and respectful of an individual or family member's values, needs and wishes, but always seeing these as being central to our thinking and system design. And again, just come back to what Don Berwick was saying, this isn't a way to the point, this is the point. This is why the healthcare system exists, to achieve that. So true person and family-centered care enhances the experience of seeking or receiving care. And that isn't just what happens when you're in the room with another provider, but it's what happens from the point at which you first pick up the phone to make an appointment, or how your last appointment is followed up. And it includes parking, and it includes how you're welcomed when you come into whatever clinic or office you're coming into. All these things are part of the experience if we're really looking at it from a person and family-centered approach. We see the person for who they are. You know, each person is different. You work with each person as though there's only one person that you're looking after. And we involve individuals and families as partners in their own care and care planning. And we support self-management. And when I talk about self-management, I mean, if you have a chronic condition, I mean, whether it's mental health, cardiac, diabetes, how much time do you think you would spend on average in face-to-face contact with a health professional over the course of a year? How many hours? It works out to be about 10, which means that 99.9% of the time you're actually looking after your own care. So how can we provide individuals and families with the tools, the information, the resources, and the support to be able to better look after their own care? And how can we make sure that the goals that a person is working towards are their own goals and they're not our goals that we've kind of superimposed or kind of suggested that this is the best way to go? We provide the information required to make decisions about their own health care, but we respect and support individuals and families' choices about their own health care. I mean, I think these are all self-evident, but it's, you know, speaking as I will be most of the time as a healthcare provider, we have to keep reminding ourselves that this is central. And I think that's when we talk about personal and family-centered care. These things are central rather than something that we can shift to one side because we're too busy to spend time talking or because there are too many other sort of imperatives that we have to deal with. The person always comes first. And I think there are a couple of other things that I just want to mention. We use the experience of individuals and families to learn where the healthcare system is working or underperforming. We ask. And again, this is something I will come back to. But it's people who are using a service who are in the best position to tell us what's working and what isn't working. And not with a questionnaire. So we say, yeah, we've got a 92% satisfaction rate and we pat ourselves on the back. Something more like a focus group. Get a group of families, get a group of people using the service together. Ask open-ended questions, including things like, what do you think we could do better? But you do that knowing that you're committed to introducing changes if they're suggested. This isn't just a sort of vacuous exercise, and again we say, yeah, we asked all the right questions. There's that commitment to making changes to enhance the person's experience, and that's true person and family-centered care. We involve people using the services in redesigning our systems of care. It's not, you know, it's the same thing, nothing about us without us. It's become a cliche, but it just makes so much sense. In any other industry, you're going to ask consumers and people using a service how we could do better. But healthcare somehow thinks it's a little bit of an anomaly, that we know best and therefore we don't need that kind of input. Involve people using the services in training new practitioners and also in governance of the healthcare system. There's one healthcare system in Southwest Alaska, the Nuka healthcare system, which has a large indigenous population, which is actually run by the people who are attending that family practice unit, and the physicians are employees of the patients of that service. So, you know, there are other models emerging, but we're a long way away. These are just some of the things that a family may need when they have a relative who is coping with an episode of an illness or an enduring illness. I won't run through them all because I know you know these, you know, as well better than I do. But really would highlight the last one as well, hope. Not in an unrealistic way, but that you're always able to work with the family, to work with the individual, to see the opportunities, you know, what is possible rather than what can't be achieved. And this just highlights, I mean, again, the importance of how we need to see the family and the roles that family can play. You know, sometimes I think we see them as sort of additions to the individual and the individual's care without realizing that they're not just there as a relative, but they're also providing a series of roles. And again, comes back to supporting self-management, the family working with the individual to help an individual stay well and to stay healthy, whether it's supporting self-management, identifying warning signs, assisting with medications, developing a relapse prevention plan, fostering a healthy living environment. And in many ways, the family members are often care managers or care coordinators and system navigators. How, again, in the new partnerships, do we work together to support all those functions and look at how the healthcare system can then reinforce rather than duplicate or undermine things that can be accomplished through an individual's more natural environment? You know, obviously there's some things that make this a little bit more complicated. You know, sometimes it's previous experiences with the system, obviously respecting the wishes of the person who is living with the problem. And again, I won't say a lot about that, but often there are different agendas pulling in different directions. And I think we need to think about different ways of beginning to approach that. The family may be defined by the person in very different ways from the way the family would see it. Sometimes there are developmental tasks around separation, individuation that haven't been completed that are getting in the way. And sometimes there are issues in family functioning that are also getting in the way of a focus on rehabilitation. And that's kind of, I guess, the point of this cartoon, separate checks. And this one as well, is penguin in the middle. I've got overprotective parents. But again, the message is the biggest untapped resource in the healthcare system are the users of the service. And you know, we keep saying we don't have enough resources, but we have resources that we're really not taking advantage of, not just in providing support in their own right, but looking at the ways in which families and users can help each other to better negotiate the healthcare system. So this is just a small personal note. My experience as a partner, my wife was diagnosed with stage 4 ovarian cancer about 5 years ago, and we've now reached 5 years of remission. So they're talking about the other C word, which is cure, although we never believe that. But these were just some of the things that struck me. And I think it's so important for us as providers to understand our own experiences and incorporate those into our thinking. So we understand as much as we can, because we never can, the experience of the person or the family that we're working with. So these were just a few of the things that struck me along the way. You know, the importance of getting copies of notes. Someone who would help as a system navigator. I know the Hamilton system well. I've been part of it for many years. I'm in a position of influence as a department chair, but we still needed someone who could help us navigate the system and someone to take charge. And it, you know, really understood this in a different way when someone just stepped in and they took over and became the quarterback of care, and how important that was. The importance of information, the importance of time, the importance of preparing ourselves for visits, but then again having sufficient time. And I will say, I think in terms of person and family-centred care, cancer centres are exemplary. I mean, this is what we should be aspiring towards. And the importance of hope. And again, looking at the person at the centre of care, I really like this quote from Tommy Douglas. Man can now fly in the air like a bird, swim under the ocean like a fish. He can burrow into the ground like a mole. Now if only he could walk the earth like a man, this would be paradise. And again, I think that's the same thing in his own way as Don Berwick was saying. So how are we doing? Well, this cartoon sort of sums it up. We're running a little behind, so I'd like each of you to ask yourself, am I really that sick, or would I just be wasting the doctor's valuable time? And this is what we're trying to get away from. This is on a site called despair.com, Dismotivators, Apathy. If we don't take care of the customer, maybe they'll stop bugging us. And again, I mean, there's more than a grain of truth, not done maliciously, but just because We're so tied up with other agendas. It was Einstein who said insanity is doing things the way we've always done them, expecting different results. I think new solutions are there, but we aren't seeing them. And by not seeing them, we're making life much harder for ourselves than they need to be. So how can we do better? Well, as I say, I think the pieces are all there, but how do we put them together? This is applying for a job at IKEA, make a chair and take a seat. So how do we improve the experience for users and families? I think I'm going to mention 4 particular ways. Always and never events, using the clinical encounter differently, increasing access to information, and using the person and family's experience to help us redesign our services. So firstly, always and never events. Always events are things that should always happen in a healthcare system. And never events are things that should never happen. So always events are those aspects of the consumer family experience that should always occur when they interact with healthcare professionals in the delivery system. And I'm sure each of you could come up with a dozen things. And I think the importance about quality improvement is we're not looking at major transformational change. We're looking at small things. One of the maxims is, what can we do by Tuesday? And some of these things are dead easy to do. These are small changes that any clinic, any inpatient unit, any primary care practice could just sit down and say, yeah, this is a problem. What are we going to do differently? Let's try it out. Let's see if it works. And then let's make sure we do it uniformly. So I would say, for example, an always event is when we send a note to another health practitioner, insurance company, whoever, we always make sure the person has a copy of the note themselves. Yeah, dead easy to do. Yeah, and it again comes back to Don Berwick. When he was told, or his friend was told, we can't do that. We can do anything we want to. We won't do that. And our systems, remember I said at the beginning, we need to change our systems, prevent us from doing that. And a never event, again, something simple. I would say we never leave someone waiting in a waiting room without telling them how long it's going to be before they see their provider. It's just a small part of the experience, but you could add a dozen things to that, in 2 minutes, and all of them are valid, and all of them, it's how we need to be thinking in terms of the way that we organize care. But we can only do that if we're seeing the person, the family at the center, because I'm too busy and I'm rushing and I've got this and I've got that, and I'll get to them as soon as I can. But the person sitting in the waiting room doesn't know that. How can we use the clinical encounter differently? Again, these are just some of the things to do with an encounter. It begins at the first contact. How easy is it to get through by phone? When you get through by phone, do you actually speak to someone who's going to be able to help you? They're the kind of things as well that set a first impression. What happens when you walk into a practice? Does the receptionist look at you as they're, clerking you in, or are they looking elsewhere? Those things, again, they set the tone for the interview. If you're already feeling a little bit grumpy because of the way you've been treated before you see your health professional, they've got a lot of extra work to do to overcome that. Avoid jargon. Listen, 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 listen. Ask about previous experiences with the healthcare system. Decision making is joint. We know if plans are going to work, they have to belong to the individual themselves. The goals have to be their own. And, we get much more mileage. Doesn't matter what we think of the goal, by starting where the person is and then working towards something that we might want to add to their plan. Because part of what we're doing is building not only a sense of trust, but the person is saying to themselves, look, they're willing to listen to me, therefore I'm willing to listen to them. I remember a story when we were doing some of the work in primary care. Someone came in and said they had a patient in their practice who was overweight and needed to stop smoking, and his wife had just died, so he's feeling lonely as well. And the doctor was going to say, what I want you to do is start exercising and take this and take that. But he asked the person, and they said, what I would really like more than anything else is to buy a puppy. And the doctor thought, this is crazy, how can he look after her? But he bit his tongue again, and his patient came back to see him 6 weeks later, and he said, how are you doing? And he said, well, I did get a puppy, and it keeps me up all night, and it screams to go out, and it's peeing all over the house, and it's the best thing that's ever happened to me. But I need to walk the dog, and I know that it's a challenge for me. So what can I do to make it easier to walk this dog? So, it's a nice example, but I think that's how we need to be working together. And I think a couple of things, ways to begin and end a visit. Always, what are you looking for today, and how can I be most helpful? And at the end of the visit, were all your questions answered? Was there anything else I could have done today? And this is where time becomes so important, because we're already, if you're saying to someone, any questions, but at the same time you're looking at your watch, you're giving them two very different messages. And again, that's where person and family-centered care comes. And we're always going to say we're too busy, we don't have. The challenge for us is how we make time, because this is the point. Helping people prepare for appointments so they get the most out of them. These are just a few things, but decide what it is that you want to make sure you talk about. If necessary, write it down. People often get a little bit anxious or tongue-tied, or they realize their doctor is busy and they don't want to bother her. So it's your time, use it, but make sure you get the things that you want answered as much as you can. Make a note of other issues you might want to talk about. Think about what you would like to have achieved by the end of the visit. Write down any specific questions you want to ask. Ask your relative what they want you to ask or what they want you to do during a visit, and bring a list of medications or the bottles. Medication reconciliation is so important, and I think is something that should be done at every single visit. In terms of increasing access to information, there are lots of ways in which this can be done. Psychoeducation groups is one way, the internet, but make sure that when you're referring someone to an internet site, make sure with all education that it's interactive. And by that I mean that you have a chance to discuss it. Otherwise you might end up with this situation. I already diagnosed myself on the internet. I either have 3 left kidneys, recurring puberty, or Dutch elm disease. But I think it's so important again that consumer education is an active process, and people have a chance to ask questions, because often our information gets misunderstood because we're just using jargon or making assumptions. I remember being in one family physician's office and seeing someone who said they got up at 1 o'clock in the morning. They weren't sleeping, but they were getting up at 1 o'clock in the morning to take their medication. And I said, why are you getting up at 1 o'clock? They said, well, that's what my doctor told me. And I said, well, what exactly did your doctor say? What do you think the doctor said? No, even simpler. They said take 1 in the a.m. And this wasn't a phrase she ever used. I had my breakfast at 7:30 a.m. and I go to bed at 1. I go to bed at 11. And she thought, she just misunderstood. But that happens so often. And medication errors are so important, and I'll come back to that in a moment. What can we do before a visit to prepare someone? Can we direct them to a website? Can we provide them with information? Can we make sure that blood tests that need to be ordered are ordered in advance, so someone doesn't come to an appointment and then have to make another appointment to come back because something we could have done beforehand we haven't done at the time? And the more prepared a person or a family is, the more productive the interaction is going to be. Written instructions, are our instructions always clear? He stuck the suppository in his ear. don't even ask about the hearing aid. There's another story I remember from England when someone goes to see his doctor and he gives him a suppository and he says to the man, what I'd like you to do is put 2 of these in your back passage every night. So the guy goes home every night, regular as clockwork, he opens his back door, puts his 2 pills in the back passage, comes back to see the doctor the next week and he says, how are you doing? He says, well, not really much better. And the doctor says, were you following instructions? And he says, I was, but to tell you the truth, Doc, for all the good it's done me, I might just as well have stuck them up my arse. So this is one simple way of, just making sure people know about medications. There are lots of other ways in which it can be done, but can't stress enough the importance of written information and interactive education that understands health literacy. The concept of talkback. If we're providing education, make sure that the person knows what it is that we talked about and what we're asking of them before they leave the office or the visit. Health literacy is so important in this regard. The abilities of individuals to find, assess and use health information to make appropriate health decisions and maintain good health, and the capacity of systems and organisations to provide that information in ways that are accessible to all. So you can see from this data, it's a little bit small, how many Canadians do have difficulty with health literacy, which is understanding the instructions to the point where you're clear about them and can follow through with them. And a greater percentage have problems with health literacy than they do with other forms of literacy. And as people get older, the health illiteracy rates just go up and up. And again, it's so simple, it's self-evident, but how can we just make sure that the information is put across in a way that people can use? And I think the other concept is one size fits one. We give out these educational materials, but it's uniform information for everybody, but how can we make sure we can help the person apply it in every single case? How do we use the user's experience to improve care? So often this is the case. We come up with these great designs, but what the person actually wants is something different. This is a nice example, just again, of using the experience of the person. This was an Alzheimer's Society, Greater Simcoe. Any thoughts when you look at that? What does it say to you or tell you? So they asked the people using the service, and they said, well, it all looks a bit cold and, dispassionate. So they just put up small thing on the bottom, big changes in small steps. Then they looked at their waiting area. So remember, this is an Alzheimer's Society, Alzheimer's clinic. Anything strike you about the waiting area? One chair. And clutter as well. And the family members pointed out that, usually they don't come to their appointments by themselves, we come with them. So, involving the consumer and family in teaching. I think this is, again, it's a different dimension on exactly the same thing. How can we draw on the experience of people who are using the services, not just through focus groups or surveys or questionnaires, but also in training us who are going to be the people who are going into practice. And there are lots of ways in which it can be done. I think just having a longitudinal relationship with a consumer or family, and our training programs aren't necessarily geared to that, but it gives you a completely different perspective. I'm still working with one person who I saw when I was a resident, and used to work with him and his wife until she died. But it just, being involved in their lives over many, many years is just an absolutely unique experience. But it's, just opened my eyes to so many different aspects of the experience of living with a chronic condition, and also all the successes that they've had along the way as well. Consumer or family mentors, someone who is going to work, say, with a psychiatry resident, just to advise them on different aspects of how better to improve the care that they're delivering. Having consumers and family members involved in teaching sessions on a regular basis, not in a token role, but in a real role where they have an opportunity to let learners into their world. Involve in planning of teaching sessions. So it's not, again, a question of saying just, can you show up and talk? It's a question of how can we best design this service, and what do you think would be the most important lessons for our learners to learn. Involving in rounds, again, in a real way, where the focus is very much on the person's experience. And at the organizational level, I think organizational consistency from top to bottom. So, and I've said from bottom to top, because I think in many ways it is the bottom that is the driver. Discussing within a team what person and family-centered care means to each team member and how to implement it. I don't know if we ever do that, but just having that kind of discussion and sharing ideas and learning from each other's experiences. Some of the principles for enhancing the person's or family experience, this is sort of at the other end now. These are the things that as an organization, always events. We will be open and transparent about everything that we do. And again, I realize all of these things, we're talking about moving towards perfection. None of these are easy, but this is what we're aspiring to, because we always want to make healthcare better. Available to answer questions, make time, be respectful and listen, do nothing that will embarrass the individual or family, don't undermine the individual's beliefs, ideas, or self-care. Getting a puppy is not the stupidest thing I've ever heard. It's a great idea, why don't you try it? And it actually was a great idea. And I'm not going to go through this, but just having a charter. This is from St. Joe's, but again, it's something that is a statement. The challenge is how this is inculcated into each of the people who are working there. So it stops, with all the stuff I've been talking about, how you go from it just being words to actions.
I just want to throw in an example, and using this philosophy, I'm going to really challenge you, and probably you're up to the challenge, but how do you apply this to, say, a mother sitting with her son for 6 or 7 hours in emergency, finally seeing the psychiatrist, and the son presents differently by that time, and then you have the privacy legislation, which he's an adult, so it's so difficult. So how do you reconcile all of your philosophy, which I really agree with, into a situation of complex mental illness?
I think, in short, it's something that we're always moving towards. So what we would like, ideally, is not always going to be possible or not possible in certain situations. I think they're, just based on the, situation that you've mentioned, I think one of the things that we can do differently is the waiting period. We can, and different places look at it in different ways, but what's the environment like? I mean, I know I'm thinking of our environment in Hamilton, in our emergency room, and we have sort of the most unwell people in some of the least health-inducing conditions. So, it's a bit of a bigger answer to your question, but can we be thinking about how we design our emergency rooms? Again, our last appointment at the Regional Cancer Centre, someone comes round with a trolley. They've got cookies, coffee, juice for people, using the service, but also for family members. Can we begin to think about how we can change that part of the experience? I think the other part about what you do, when someone is saying no family involvement, I think the key is to see that as the starting point, not the end point. So it's not that you break off discussions, you try and understand why that might be, you try and look at what some of the factors are. It doesn't mean that you can change everything today in the emergency room. But what you're trying to do is build a situation where, if not today, if not the next visit, maybe 3 months, 6 months from now, there'll be a little bit more of a rapprochement. What are the things that are the common elements between the family members that you can draw on, that they can both connect with, rather than what are the things that pull them apart? And focus the interview or the session on those kind of things, and don't, get into this. I mean, both. It's slight. Things that provoke a confrontational response between the family members, because what you're trying to do is to create the best possible environment you can between them at that particular moment in time. You're trying to build positive experiences that they can draw on down the road, but you're also, I think, as a health professional, you're aware of where you need to set limits and where you don't go into areas that are only going to make the situation worse. The changes need to be real and not just cosmetic. So we're not just putting up a different sign, hurry up with the sign, here comes a tourist. But what we're doing is we're actually committing to making those change. And they say again in quality improvement, you need 3 things. You need will, ideas, and execution, but will always has to come first, because if the will isn't there and you're not willing to make the changes that family members are suggesting, you may as well save your breath to blow on your porridge. So the last thing I want to just take 5 or 10 minutes to talk about is the concept of changing our systems of care to improve collaboration between mental health and primary care services. We know that there are many challenges in the way our healthcare is organised. One of them are some of the challenges between primary care and mental health services. Why do we need to collaborate better? I think for all of these reasons. The majority of mental health care in every city in Ontario is delivered by family physicians, but often without adequate support from mental health services. And without us understanding not only what their role is, but the potential of their role. Because with additional resources and supports, as I'll describe in a moment, when we've integrated psychiatrists and mental health counsellors into primary care, the range of services that can be offered in primary care can be transformed. Communication is always an issue. Problems in accessing services and frustration at the waiting times and the delays, whether it be immediate, as you're describing in ED, or whether it be for any other aspect of mental health care where you may have to wait. And we need to use our resources more efficiently. I think right across the healthcare system, we have to make sure that we're taking advantage of the full potential of everybody within the healthcare system and using our specialised resources as sparingly but as effectively as we possibly can. We need to reduce the fragmentation of care, and people using the services want it. And I think they're coming to expect providers to talk together, not just mental health and primary care, but right across the board. This is the Hamilton Family Health Team in Hamilton, the city of waterfalls. We have 125 waterfalls, and at least 3 or 4 of them are higher than that table. So the model in the Hamilton Family Health Team is that in each practice, and we have 90 practices, 170 family physicians, we've integrated mental health counsellors and psychiatrists. Mental health counsellors are there. If you have 4 people in a practice, you have a counsellor full-time. If you have 1 person, you're a solo practice, you have a counsellor for maybe a day and a half, a quarter of a week. Psychiatrist time, we've worked out a ratio that says half a day of psychiatrist time per family physician per month. So tomorrow morning, I'm in a practice with 4 physicians, and I'm there once a week, half a day for each of the 4 physicians. And that, it's not a question of is it right, it works. But in all of these situations, we just take advantage of the resources that we have. and how we can use them, and anything we can do to improve care is a step in the right direction. Within the Canadian collaborative care model, there are 5 key partners, and if you notice, the person and family is always at the centre of what we're talking about. The family physician still delivers the bulk of mental health care, but the difference is they're much better supported. You know, they can see a wider range of people because they have access to a psychiatrist who's in the office once a week or once a month, who can advise them around care, can advise them around resources, can advise them about changing medication doses, or can answer specific questions they may have. The kind of backbone of our program is the mental health clinician, who is in the practice and seeing, you know, when we're in primary care, we'll see anybody. There's no exclusion criteria. You know, when I came out of my residency, for about 10 years, I used to follow the advice that you see on medication bottles, where it says, keep well away from children. But, you know, at a time I was seeing probably 100 new children a year in various practices, because, you know, the waiting time for service is a year, and if we can't initiate care, a year lost to a child is probably even more significant than it is to an adult. So the counsellors will see people, they'll advise family physicians, they'll help with referrals, there'll be system navigators, there'll be care coordinators, and generally are integrated as part of the primary care team. Psychiatrists, when they come in, I'll walk into the practice tomorrow morning. I have no idea who I'm going to be seeing. I know there are going to be a couple of, maybe 2-3 new consultations. There'll be some people that I've seen in the past. And we tend to work more like family physicians. So I may see, or the counsellor may see someone 5 or 6 times during an acute episode. And then they may not need to be involved with us for 6 months, a year, 2 years, 3 years. But we're always part of the team. We can always be talking with the family physician or the practice nurse about, you know, care. And also, speaking as a sort of psychiatrist, it's great to know how people are doing, because often, you know, when they're discharged from our service, we don't know what happens in primary care and we don't know what their outcome is. And if it's something that needs an adjustment, or could you see again because there's a question about diagnosis, or could we change the medication, it can be done seamlessly and in 2 minutes tomorrow morning, rather than someone needing to go back on a waiting list for an outpatient appointment. All of the primary care team are involved. You know, in the Hamilton Family Health team, we have dietitians, we have pharmacists who do a lot of the consultation around psychotropic medications, dealing with people who want to come off opiates, benzodiazepines. We have practice nurses who are often the enduring contact in the practice for people with severe and persistent illness. We have dietitians who are working with, say, people with diabetes who are depressed, working with people with eating disorders, you know, working with people who are looking at bariatric surgery. So all kinds of things open up where we're in primary care. 4 major roles: recognition, assessment, initiation of treatment, care management, relapse prevention, education and support for self-management, protection of human rights and equity. And I think these are consistent with the things that we're talking about. But when we're in primary care, these are all things we have an opportunity to do in a very different way from how we're usually able to do that, because we're seeing and we're able to be part of someone's life across the whole duration and spectrum of their illness. Within this model, the role of the service user, I mean, again, these are some of the things that we were talking about before, but again, the idea of this being central to the care that we deliver. And when we look at some of the benefits of collaboration, you know, just summarizing a few, for people using the service, they have ready access to initial assessment, treatment, and ongoing monitoring. So, for example, tomorrow morning, this afternoon, I may have got a call from a family physician saying, I've just seen someone, I'm a bit worried about them, could I book them in to see you tomorrow morning? And either I'd stay a bit longer, or I'd say sure, and they'd say, yeah, well, maybe we can just rearrange your morning and put someone else off for a couple of weeks. But that kind of thing just is difficult to do in traditional system. It's more convenient, and it's much less stigmatizing. You know, for a lot of people, they're just walking into their family physician's office. They're not walking into a mental health facility. And not only stigmatizing, but I think one of the things we don't think about enough is the trauma of having been through the mental health system and your various experiences. And there are a lot of people who talk about, you know, mild but real symptoms of post-traumatic experiences when they go back into a hospital or a clinic, particularly if they haven't been treated in the way that they should have been. Waiting times are shorter, outcomes are good. I mean, always remember quality, safety, and effective were two of the primary things that we're looking at. Collaborative care is a means to an end, and the end is better outcomes, not nice partnerships. There's greater continuity of care. We can integrate physical and emotional care, and often it's much more culturally congruent because the family physician or someone in the practice may be from that individual's culture or speak their language. And many people are deterred from going to mental health services because they worry about language or culturally congruent services. And it's also, I think not only are we as mental health providers contributing to primary care, but we're learning an enormous amount, about sort of the context of mental health care. For families, again, it's mental health care in a familiar environment. They may know some of the mental health care team because the mental health care team is not just the psychiatrist and the mental health counsellor, but the nurse, the family physician, the receptionist, who may spend more time with a person over the course of a year when they come to visit their family physician than anybody else in the team. There are also multiple entry points into a family problem in primary care. So, coming back to the example that was raised before, someone isn't coming in for their appointments, but we do have regular contact with other family members. We have other ways of reaching that individual, around other aspects of their healthcare, for example. So there are lots of things that we can do in primary care that we can't do in a traditional in and out mental health service. Primary care is also aware of, the whole person's lifetime experiences. I can remember a couple of family physicians where a number of conversations about someone who is now in their 20s, in their late 20s or early 30s, and it begins with, I can remember when I delivered this kid. But they know the whole story. They may not be able to frame it the way that I might, but it doesn't mean that my framing is the right way. So I think when this works best, it's when that kind of longitudinal knowledge is sort of married to different skills, different approaches, different ways of looking at a problem. And again, less stigmatizing, easier to see. The benefits for primary care, increased support. Family physicians are likely to do a lot more continuous and better coordinated. Increasing the capacity. We're not only increasing the capacity of primary care, because primary care is able to effectively manage a much wider range of problems and issues. We're increasing the capacity of the whole mental health system because we're now seeing primary care as an integral part of the mental health system. Care is more efficient and it's usually more effective because a lot of the things that get in the way of effective care are no longer in the picture. And I think the last point is that collaborative mental health care can assist with other health system challenges. That when we're working together in primary care, we can reduce access. And these are problems that are universal, I think, in every healthcare system. We can reduce access and waiting times. We can reduce fragmentation of services. We can prevent avoidable ED visits. We can improve transitions, particularly, I think, between child and youth services and adult services, but all kinds of other transitions. Someone's discharged from one service and is waiting for the next. If the family physician is centrally involved, they can play that kind of quarterback role that we found so helpful, in the situation that my wife and I were dealing with. It improves the quality of care. As people get older, it's much easier to deal with complex or multiple conditions. It's definitely a way of delivering service to rural and isolated communities, and I think we can address inequities because of all the things that we're improving. And there's also been some work done by a family physician in Toronto just looking at treating poverty in primary care because of all the things that contribute to inequities. Poverty is probably the single most important factor. And there are things that can be done in primary care. But all of these things are more likely to happen if mental health and primary care services are working together. And the last point is early detection. And I mentioned before, I'm not a child psychiatrist, I see a lot of children. The thing that I have learned most, I would say, in all my time working in primary care over the last 35 years, is that the lack of resources that's paid to children's mental health is, I would say, criminal. We have an opportunity to change trajectories. This is where we should be investing. And we can see, and, this is a quote from T.S. Eliot, "In my beginning is my end." And we can see when we look through so many of the charts that there are points to intervene when the child is 3 months and 6 months and 1 year and mum comes in and she's abused, and 2 years there's a behaviour problem, and at 4 years, but we don't see the kid until he's 16 or 17 and he's in trouble with the law and he's dropped out of school and there are major family issues. So, I would say that is one of, if not the most important focus, not just for collaborative care, but for for healthcare systems. So really just, not to summarise what I've said, but not everything we try is going to work, but for challenges that seem insurmountable, this is Doctor Who, the Daleks, this certainly buggers our plan to conquer the universe. Remember, there are always solutions. And when nothing seems to come up with a solution, the thing that keeps me grounded are our grandchildren. Thank you.